Are you able to hear me? Hello?
Sir.
Everybody able to hear me?
Yes, sir.
Right. Okay, good. Okay. So, good morning, everybody. Today's topic is I am Dr. Rakesh from Department of Pulmonology, Assistant Professor. Today's topic is about interstitial lung disease. So, interstitium. What do you mean interstitium? So, interstitium basically it is the space between the epithelium and endothelium basement membranes of the lung. But the term interstitium is actually a misnomer because it is actually a loose connective tissue. It is actually a loose connective tissue present almost throughout the lung. It is present almost throughout the lung. It is a loose connective tissue. There are subdivisions. It is divided into 3 subdivisions: bronchovascular, parenchymal, subpleural. Bronchovascular, it surrounds the loose connective tissue is present surrounding the bronchi, arteries, veins from the lung root to the level of the respiratory bronchiole. So parenchymal, this is situated between the alveolar epithelium and capillary endothelium basement membranes. Subpleural, situated beneath the pleura. Beneath the pleura, that is at the peripheral parts of the lung. It is subpleural. So bronchovascular, parenchymal, subpleural. So it is divided into 3 subdivisions. This interstitium generally is not visible. It becomes visible radiologically only if there is in the presence of disease process. So disease process causing edema, fibrosis, tumor. So all this gives rise to the appearance of the interstitium. As the attenuation means the lung, the density, the density will increase. So the lung density will increase, making the interstitium visible. So this diagram, it is showing the space between the alveolar epithelium and the capillary endothelium, that is the interstitium. So you see this diagram, normal lung and interstitial lung. Interstitial lung is interstitial lung, as I told in the previous slide, it is a misnomer. Because it almost involves the entire throughout the lung. So the correct word better than interstitial lung disease is DPLD, diffuse parenchymal lung disease. This is a more appropriate word than interstitial lung disease. So interstitial lung disease or diffuse parenchymal lung disease involves many diseases. So out of all these diseases, the classical disease is idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis. So you compare with this in this diagram. So to my right side it is showing idiopathic pulmonary fibrosis lung, and to my left side it is showing normal lung. So you observe this both lungs. In the idiopathic pulmonary fibrosis lung, you see that lung architecture is extensively distorted. The lung architecture is extensively distorted with because of the extensive fibrosis and traction bronchiectasis. So we were able to see this honeycomb appearance. Okay, this lung architecture is showing appearance as if you see the basal regions of the lung. It's showing like a honeycomb appearance. So interstitial lung disease, more than 200 diseases can result in interstitial lung disease. 3.5 men per 1 lakh men. Okay, and 26.1 female per 1 lakh women. And so this many number of people per 1 lakh group of people are noticed interstitial lung disease. As per 15% of the respiratory physician practice, we are able to notice this interstitial lung disease patients. There will be usually 1 lakh hospital admissions every year. Spectrum of interstitial lung disease or diffuse parenchymal lung diseases. So there are many group of diseases that are included in diffuse parenchymal lung disease or interstitial lung disease. Occupational lung disease, drug-related lung disease, idiopathic interstitial pneumonias, connective tissue disorders, systemic diseases, idiopathic interstitial pneumonias. There are many diseases that are included. Again, idiopathic interstitial pneumonias are divided into like usual interstitial pneumonia, non-specific interstitial pneumonia, lymphoid interstitial pneumonia, acute interstitial pneumonia, respiratory bronchiolitis associated ILD, desquamative interstitial pneumonia. There are many subdivisions are there. Occupational lung diseases, based on the occupation. For example, a patient who is a coal worker working in coal work is a coal worker. Patient is a coal worker. Is prone to get coal workers pneumoconiosis. For example, a patient working in stone quarrying is able to prone for silicosis. Okay. drug-related diseases. Many drug diseases like antimicrobials, nitrofurantoin, isoniazid, okay, anti-metabolic drugs, chemotherapeutic agents, immunosuppressants, all this can cause interstitial lung disease. Connective tissue disease like rheumatoid arthritis, systemic lupus erythematosus, dermatomyositis, polymyositis, systemic disease like autoimmune disorders like sarcoidosis. So all this can result in interstitial lung diseases. So pathogenesis, original hypothesis, when there is a stimulus. So when there is an inciting trigger, because of this inciting trigger, when this inciting trigger acts on the lung epithelium, so there will be chronic inflammation because of the many inflammatory cells like neutrophils, eosinophils, T lymphocytes, monocytes, okay. And with the help of the inflammatory mediators like interleukins, IL-4, 5, 10, 13, also with other inflammatory mediators like TGF beta, TGF alpha, there will be significant amount of inflammation. This all chronic inflammation, with the help of these chronic inflammatory mediators, with or without fibrogenic mediators, it will result in a lung injury. So this lung injury ultimately result in a fibrosis of the tissue. So this new hypothesis, same thing. The stimulus will be the repeated stimulus, the inciting trigger, the allergen. There will be repeated exposure to the inciting trigger of the allergen that leads to the sequential lung injury. That leads to the sequential lung injury, repeated lung injury, that again result in the chronic inflammation and leads to chronic inflammation. And also here genetic factors also play a role. This chronic inflammation because of the inflammatory mediators leads and with the help of the tissue plasminogen activator, which is a key modulator in fibrotic pathway. So all this will cause aberrant wound healing. And there is also TH1, there will be TH1 imbalance between the TH1 response and TH2 response. There will be predominant TH2 response. So predominant TH2 response that leads to the more and more disease happening. So this TH2 predominant TH2 response, along with more and more fibrinogen mediators, it will cause more and more fibrosis, extensive fibrosis that leading to the extensive destruction of the lung architecture. So you see this diagram. So initially, when inciting trigger of the allergen exposure to the lung epithelium, there will be epithelial damage and activation of the inflammatory cells, inflammatory mediators, fibrogenic mediators like TGF beta, TNF alpha, delta derivative growth factor, everything. So this all cause chronic inflammation. So afterwards, you see this plasminogen activator will be there. Come into action. Plasminogen activator inhibitor. This plasminogen activator inhibitor 1 and 2. It has a very key. It plays a very key role as a modulator in fibrinolytic pathway. So this tissue factor plasminogen activator inhibitor 1 and 2, as it has a key role in modulation of fibrinolytic pathway. It helps in the wound clot. It helps in the process of wound clot and healing of the wound. So thereby there will be formation of the fibroblasts, more and more fibroblasts, and this fibroblasts migration will happen and the proliferating the multiplication of fibroblasts will occur, and these fibroblasts will get migrated. So, and with the help of these enzymes like gelatinases A and B, there will be basement membrane disruption. So basement membrane of the alveolus of the capillary there will be disruption of the basement membrane. So further afterwards, there will be also angiogenesis, myofibroblast foci formation with the influence of the inflammatory mediators like vascular endothelial growth factor, and with the help of the angiotensin II, there will be epithelial apoptosis. There will be imbalance between the matrix metalloproteinases and transmembrane inhibitor metalloproteinases. This again will cause more and more fibrosis and impaired reepitheliation. So ultimately leading to the destruction of the lung architecture and formation of the honeycomb appearance. So this diagram, as explained now, it represents the fundamental response of the lung to the injury. Interstitial lung disease, that is diffuse pharyngeal lung disease, can be classified based on the known cause, like drugs, the drugs, like many drugs, as I told you before also. So drugs like anti-metabolite drugs, anti-cancer drugs, antimicrobials, nitrofurantoin, isoniazid, immunosuppressive agents like cyclophosphamide, azathioprine. So all these drugs and also like other causes like asbestosis, granulomatous diseases like sarcoidosis. Other forms of interstitial lung disease like lymphangiomyomatosis, Langerhans histiocytosis, idiopathic, like even idiopathic interstitial pneumonias. These idiopathic interstitial pneumonias can be UIP or NSIP. UIP is usual interstitial pneumonia. The usual interstitial pneumonia is typical example for is idiopathic pulmonary fibrosis. Other than IPF, there will be non-specific interstitial pneumonia, cryptogenic organized pneumonia, discriminative interstitial pneumonia, that is deep lymphoid interstitial pneumonia, acute interstitial pneumonia, respiratory bronchiolitis, ILD. Okay. So basically on the duration, acute, subacute, chronic. So acute days to weeks, less than 3 weeks. Examples for acute diseases are eosinophilic pneumonia, hypersensitive pneumonitis, bronchiolitis obliterans organized pneumonia. Subacute examples, sarcoidosis, connective tissue disorders. Chronic examples greater than 12 weeks, period. IPF, idiopathic pulmonary fibrosis, sarcoidosis. Interstitial lung disease. So this interstitial lung disease, as described before in the pathogenesis, there will be basically two forms: usual interstitial pneumonia, non-specific interstitial pneumonia. In usual interstitial pneumonia, there will be the pathogenesis pathogenesis ultimately leads to the fibrosis. Whereas in non-specific interstitial pneumonia, the pathogenesis ultimately may lead to fibrosis, or it may remain in cellular form. It may be in cellular form or it may be in fibrotic form, which is non-specific interstitial pneumonia. But usual interstitial pneumonia, definitely the pathogenesis will lead to ultimately in fibrosis form. So interstitial lung disease basing on the history. So age, we have to consider first thing is age. So generally age group of 20 to 40 years, more commonly they will prone to sarcoidosis, connective tissue disorders like rheumatoid arthritis, systemic lupus erythematosus, many other there. Idiopathic pulmonary fibrosis is a classical example of usual interstitial pneumonia, which is seen usually in greater than 50 years age group people. So basically on the gender, premenopausal female. In premenopausal female, you will notice lymphangiomyomatosis. In female, this is the female. In connective tissue disorders related ILD also, female predominance is noticed. Male predominance is rheumatoid arthritis associated ILD, non-pneumoconiosis. Smoking. So diseases associated with smoking history: discriminative interstitial pneumonia, respiratory bronchiolitis, ILD. Pulmonary hemorrhage is far more frequent in chronic smokers. Family history. So family history, for example, if you see idiopathic pulmonary fibrosis, autosomal dominant pattern is noticed. Autosomal dominant pattern. In not only idiopathic pulmonary fibrosis, even in non-specific interstitial pneumonia also. So some cases of non-specific interstitial pneumonia, immunoglobulin autoimmune deficiency has been noticed. Autoimmune deficiency has been noticed in some forms of non-specific interstitial pneumonia, but majority of the non-specific interstitial pneumonia, the pathogenesis is a different hypothesis pathogenesis because of connective tissue disorder. It may be because of connective tissue disorder or hypersensitive pneumonitis. In some forms of non-specific interstitial pneumonia, because of the fibrosis, the pathogens will mimic same as to that of the pathogenesis of idiopathic pulmonary fibrosis, where the similar as in both there will be fibrosis. That is the IPF with fibrosis and non-specific interstitial pneumonia. This is also with fibrosis. But some cases of non-specific interstitial pneumonia can be without fibrosis, that is cellular form. So where in some cases of non-specific interstitial pneumonia, some autoimmune deficiency also noticed, like in IPF, where autosomal dominant pattern is noticed. So autosomal dominant pattern, not only IPF, sarcoidosis, neurofibromatosis, autosomal recessive pattern is Gaucher's disease. So Gaucher's disease, Gaucher's disease is a metabolic disorder where there is a abnormal fat accumulation. So there will be enlargement of liver spleen, there will be abnormal fat accumulation, there will be deposition of glucocerebrosidase in position in between the monocyte and macrophage system. So this Gaucher's disease also leads to interstitial lung diseases. So you see these diagrams on chest X-ray. So this lady is showing a potato-like nodules over the nose, and you see the chest X-ray. hilar lymph nodes are there. Typical hilar lymphnodopathy is there. So this suggests to have a clinical diagnosis of sarcoidosis. Classical example. So drugs that cause ILD, nitrofurantoin, sulfasalazine, aspirin, gold, anti-inflammatory agents, chemotherapeutic agents, bleomycin, mitomycin, so methotrexate, azathioprine, cyclophosphamide, immunosuppressants. Okay. Even sometimes, so misuse of oxygen also can lead to development of acute interstitial pneumonia. So so certain other illicit drugs like heroin, methamphetamine also can cause ILD changes. Chemical agents, nitrogen dioxide, source of exposure in people working in agriculture, who is in agricultural labor, is exposed to nitrogen dioxide. So source of exposure, if it is electric arc welding, nitrogen oxide, accidental spills, chlorine, persons who are working in manufacturing sulfides, fumigants. So all these are, those people are exposed to sulfur dioxide. In patients who are mechanically ventilated, they are exposed to high concentrations of oxygen. Even sometimes high concentrations of oxygen, when there is a misuse, can lead to development of interstitial pneumonia. So this person is having parrot. See this because with the help of this persons who are having this when they are exposed to more and more birds like pigeons, especially pigeons, parrots, they are prone to get the interstitial lung disease, especially hypersensitivity pneumonitis. This hypersensitivity pneumonitis is more common in these persons who are exposed to these birds, especially pigeons. Okay. Inorganic dust that are associated with pulmonary infiltrates. So cutting inorganic dust like coal, graphite, silica can cause silicosis, asbestos, can cause asbestosis. Okay. So people who are working in mining, cutting, okay, tunneling, sandblasting work, carpentry work, automobile industries. So those are more prone to exposed to silica, asbestos, graphite, coal, and then in those the interstitial lung disease like pneumoconiosis, silicosis are more, asbestosis are more common. So physical examination of interstitial lung disease, basically the patients come with a history of progressive breathlessness. They will come with a history of progressive breathlessness. Of course, even they may come with acute breathlessness also, but generally they will come with progressive breathlessness. So dry cough will be there, finger clubbing will be there, skin may show rashes, ulcers, joint swelling may be there in associated connective tissue disorders. So leg edema, load, if there is associated carpulmonal, or pulmonary hypertension, you may be able to hear loud P2. So lung crackles will be there, fine, dry. These are especially in patients with idiopathic pulmonary fibrosis are called as Velcro crackles. So diagnostic approach. So the patients may get systemic systems may be involved in case of ILD. So fever, if they may have fever, so we have to suspect, we have to rule out infections because of immunodeficiency, eosinophilic pneumonia, drug reaction, vasculitis, connective tissue disorders, cryptogenic organism, extensive alveolar disease, hypersensitive pneumonitis, sarcoidosis, AIDS, lymphoma, lymphangitic carcinoma. So skin rashes can be seen in sarcoidosis, connective tissue disorders, scleritis, keratoconjunctivitis, Zika can be seen in Sjogren's syndrome, UAT, sarcoidosis, Raynaud's phenomenon, systemic sclerosis, hypertension, lacrimal salivary gland enlargement, lymphadenopathy can be seen in sarcoidosis, lymphoma, pericarditis, hepatosplenomegaly, arthritis, hematuria, oral candidiasis, especially in case of immunodeficiency conditions like HIV patients, or patients who are with fungal infections, who are on immunocompromised, having long-term corticosteroid exposure. So if you come to histological diagnosis, so firstly, basically we have to come from the bottom, that is from the clinical presentation. So initially the history is very important on the clinical presentation, followed by occupational exposure. We have to thoroughly rule out occupational exposures. So we have to look into if there are any associated diseases also. So smoking status is also very important. So and afterwards, you have to look into the radiological findings. So ultimately into the histological diagnosis when there is no proper diagnosis from the history or from the radiological, if there is suspicion of diagnosis. So laboratory evaluation, peripheral eosinophilia greater than 10% is seen Some systemic diseases like Chuck-Strauss syndrome, chronic eosinophilic pneumonia, peripheral eosinophilia will be greater than 10%. Abnormal renal function, pulmonary renal syndromes, precipitating antibodies to specific antigens are the markers of exposure sensitization. So, antinuclear cytoplasmic antibodies, anti-GM, so rheumatoid factor ANA, anti-DNA, these are all very useful in ruling out of connective tissue disorders related to ALD. So patterns of interstitial lung disease, there are 4 patterns, especially if you see the radiologically, there will be 4 patterns: linear, reticular, nodular, reticulonodular. So these diagrams you see, so linear, reticular, typical reticular, it will give rise to honeycombing appearance as in idiopathic pulmonary fibrosis. So nodular pattern, so reticulonodular again. Both reticular, in this reticular may be predominant or nodular pattern may be predominant. So linear pattern. In this linear pattern, you may find this linear pattern is seen because of the thickening of the interlobular septa. There will be septa in between the lobules. That is the interlobular septa. So the thickening of the interlobular septa will give rise to the linear pattern radiologically. So you can find Kerley A lines or Kerley B lines. So Kerley B lines predominantly seen at the lung basal regions. Kerley A lines, they originate from the hilum. They are seen from the hilum point. So this interlobular septal thickening is usually commonly seen in case of cardiogenic pulmonary edema. So not only in pulmonary edema, other differential diagnoses can be in mitral. These Kerley lines can be seen in mitral stenosis, lymphangitic carcinomatosis, malignant lymphoma, idiopathic pulmonary fibrosis, pneumoconiosis, sarcoidosis. So these diagrams are all showing interlobular septal thickening. So reticular pattern results from the superimposition of the irregular linear opacities. This linear pattern, only these linear opacities, superimposition of this irregular linear opacity will give rise to reticular pattern. So classic reticular pattern is seen in pulmonary fibrosis. So you see this diagram. So chest showing chest X-ray as well as CT scan. So here it is showing microcystic changes that are stacked on one top of the other, predominantly present at the lung bases. So along with this arrow marks are showing traction bronchiectasis. So here arrow marks in the CT scan that is showing, that is pointing to the traction bronchiectasis. That is the dilated abnormal bronchi. So there is a traction bronchiectasis. So this classically, if you see this microcystic honeycomb changes that are stacked on one top of the other, that is present predominantly at the lung bases along with the traction bronchiectasis, it will imply there is significant amount of fibrosis. So and this typical pattern of fibrosis is also called as honeycomb pattern. This is seen classically in idiopathic pulmonary fibrosis. That is the end-stage lung fibrosis. Nodular pattern. Nodular pattern consists of multiple round opacities. So then they are arranged in diameter from 1 mm to 1 cm. Nodular opacities may be described as miliary, 1 to 2 mm size. They may be small or medium or large size also. So this CT scan is showing is an example of disseminated histoplasmosis, nodular ILD. Circumscribed nodular, you are able to see circumscribed nodular lesions in the upper lobes, predominantly in the upper lobes of the lung. So this is an example for some disseminated histoplasmosis. This is a nodular form. This is a nodular opacities are present. So this is again metastasis. This is miliary opacities. This is miliary opacity. To say it is a miliary, generally the size of the nodule should be 1 to 2 mm. So this is appearing like more than 1 to 2 mm in size. So these nodular opacities which are more than 1 to 2 mm in 1 to 2 mm size and are very much disseminated throughout the lung, we have to suspect metastasis. So this is an example for hematogenous metastasis. So differential, there are many differential diagnoses of this nodular pattern. So histiocytosis, Langerhans cells, histiocytosis, LCH, hypersensitive pneumonitis, rheumatoid nodules, infection with even infections like mycobacterial fungi variola can also cause nodular pattern of disease. Metastasis, microlithiasis, pneumoconiosis like silicosis, collococcus, berylliosis, all this can cause nodular pattern. So reticulonodular pattern. This reticulonodular pattern, so both reticular and nodular pattern will be there. So reticulonodular, it results from the combination of both reticular and nodular pattern. This pattern is often difficult to distinguish from the purely reticular or nodular pattern. So basically, the rule number 1 is if there is acute appearance, it means acute appearance of these changes like linear opacities, like linear opacities, or nodular opacities, or reticulonodular opacities. The appearance is acute. We have to suspect if is there any pulmonary edema or is there any pneumonia. If it is acute appearance. So this diagram it is showing again reticulonodular opacities, especially predominantly in the upper lobes of the lungs. This is an example for disseminated histoplasmosis. So rule number 2 is reticulonodular opacities if they are present predominantly in the lung basal regions. If they are present predominantly in the lung basal regions, the classic best examples are asbestosis, aspiration pneumonia, pulmonary fibrosis, collagen vascular diseases. So asbestosis, these diagrams are showing. If you carefully, if there are the plural, see peripheral regions. The arrow marks are pointing towards the peripheral regions. That is showing the pleural plaques. Those are pleural opacities, pleural plaques, pleural calcifications. So these pleural calcifications in CT scans are also showing white density. Arrow marks are pointing towards the white density. That is the pleural plaques, pleural calcification. It is resulted because of the asbestosis disease. Again, this diagram also is showing same calcified lesions, calcified nodular opacities, and you see the arrow mark is pointing. CT scan it is showing arrow mark pointed towards the dilated esophagus. This dilated esophagus will, along with the reticulonodular opacities, we have to suspect interstitial lung disease. That is scleroderma. We have to suspect scleroderma. So rule number 3 is middle. If there is a predominant these reticulonodular opacities are predominantly seen in middle or upper lung of the upper zone of the lung. So it can be because of the microbial infections or fungal disease, silicosis, sarcoidosis, LCH, Langerhans histiocytosis. So this diagram is an example for the complicated silicosis. So it is showing multiple nodules predominantly involving upper and mid lungs. So these nodules there is covalence of these nodules. That is because of the progressive massive fibrosis. These are again examples of Langerhans histiocytosis. CT scan and chest X-ray is showing hyperinflation also. So hyperinflation with bizarre shaped cyst. The cystic, there are few cystic arrow marks are pointing towards a few cystic lesions. So these are the bizarre shaped cyst. So some bizarre shaped cysts are there along with areas of some hyperinflation, emphysema areas are there. So both obstructive defect is there and restrictive defect is there. So associated lymph rule number 4, there is these patterns like the reticular linear patterns. If they are associated with lymphadenopathy, so we have to suspect if there is associated lymphadenopathy along with interstitial lung changes. We have to suspect sarcoidosis, neoplasm like lymphangitic carcinomatosis, lymphoma metastasis, infections with viral, microbial, fungal, and silicosis. So again, this diagram is showing. Now, well circumscribed nodular opacities 2 to 3 mm in diameter. So, and you see the calcified lymph CT scan is showing calcified lymph nodes. The lymph nodes are calcified, present at the hilum region. Hilum region, the subcanal region. The white, thick white density opacities are the calcified lymph nodes. So, in the presence of calcified lymph nodes, we have to rule out all as it like sarcoidosis, neoplasm, new infection, silicosis, all this we have to rule out if there is associated lymphadenopathy. So especially if the calcified lymph nodes are present, we have to suspect asbestosis. Is there any asbestosis related diseases? So rule number 6 is if the associated pleural effusion is present along with interstitial lung disease changes, we have to rule out pulmonary edema, lymphangitic carcinomatosis, lymphoma, connective tissue disorders. So this diagram it is showing enlargement of the azygous vein. And peribronchial coughing. Peribronchial coughing is a peribronchial agent appears like a cough. So does this okay? So there is enlargement of the cardiac shadow. Okay, this is an example of cardiogenic pulmonary edema. Lymphangitic carcinomatosis. This CT scan is showing there is a perilymphatic. The nodules are there is a perilymphatic spread of the nodules. There is perilymphatic spread of the nodules. Okay. In this perilymphatic spread of the nodules, the classical example is lymphangitic carcinomatosis. So, and it is also it can be even large cell bronchogenic carcinoma. So it may be even unilateral. It may not be bilateral. This lymphangitic carcinoma may cause unilateral lung. So the rule number 7 is if there is associated pneumothorax, it suggests lymphangioliomatosis or Langerhans cystosis. This interstitial lung disease, if there is associated pneumothorax. Interstitial lung disease, if the associated pneumothorax is present, it will suggest LCH. So you see the CT scan here. CT scan, it is showing bilateral thin wall cyst along with loculated right pneumothorax. The pneumothorax is present, it is loculated. So if the interstitial lung disease is acute, we have to rule out pulmonary edema, pneumonia. Okay. If the interstitial lung disease, if you suspect interstitial lung disease changes and there is pleural effusion, we have to rule out pulmonary edema, lymphatic carcinomatosis, lymphoma, collagen vascular diseases. If there is interstitial lung disease changes and is there associated pneumothorax, we have to rule out lymphangiomyomatosis and LCH, Langerhans histiocytosis. So if there is predominantly below the lung bases, the interstitial lung disease changes are present at the lung bases and there is decreased lung volume, we have to rule out asbestosis, aspiration, pulmonary fibrosis, collagen vascular diseases, all this we have to rule out. So if there is middle and upper lung predominant, we have to rule out is the interstitial lung disease caused by microbacterial diseases or fungal disease, silicosis, sarcoidosis, LCH. If there is associated lymphadenopathy, interstitial lung disease changes with associated lymphadenopathy, we have to rule out sarcoidosis, neoplasms like lymphatic carcinomatosis, lymphoma, metastasis, infections with viral, microbial, fungal, silicosis, all this we have to rule out. Pleural thickening, pleural calcifications, or even lymph node calcifications, we have to rule out asbestosis. So basically to understand this interstitial lung disease or changes in this interstitium. So there are many changes that can happen in the interstitium, like edema changes. Edema changes can cause interstitial septal thickening. Fibrosis will cause microcystic appearance, that is honeycomb appearance. Fibrosis. So if you want to appreciate this microcystic appearance or interstitial interlobular septal thickening, traction bronchiectasis, okay, all these interstitial lung changes, basically we have to understand the secondary pulmonary lobule. This is a secondary pulmonary lobule. So many secondary pulmonary lobules are involved in the primary lobule of the lung, or the lobe of the lung. In this secondary pulmonary lobule, there are two lymphatic systems, central network, peripheral network. This central network runs along the bronchovascular bundle. So this central lymphatic, the lymphatics that run along the bronchi vessels, that is along the bronchovascular bundle towards the center of the lobule. This is a central lymphatic network. Peripheral lymphatic network it is located within the interlobular septa. There is septa between the two lobules. Okay. That is called as interlobular septa. Okay. If this lymphatics present within the interlobular septa, then is called as along the pleural linings, is called as a perilymphatic area or peripheral network of lymphatics. So this diagram is showing. So lymphatics 1 is the central lymphatics. Lymphatics 2 is the peripheral lymphatics. That is a perilymphatic area. Perilymphatic area is present within the interlobular septa. Lymphatics 1, that is the central lymphatics present in the surrounding the bronchovascular bundle. So these lymphatics are very much responsible to cause changes in the interstitium. So central lobular area, that blue dot, that large blue dot, it is a central lobular area, it is a central part. So the disease has to happen in this central part or central lobular area. Generally, the disease has to enter through the lung through the airways. Examples are hypersensitive pneumonitis, respiratory bronchiolitis, central lobular emphysema. Perilymphatic area, peripheral part, that is a disease has to happen in the interlobular septa. This has to happen in the interlobular septa along the lymphatics, along the perilymphatics. Okay, so disease has to happen in the interlobular septa to form a perilymphatic spread appearance of the interstitium. Examples are sarcoidosis, lymphatic carcinomatosis, pulmonary edema. So basically, in the CT scans films, radiological CT scans films, to appreciate this interstitial lung disease, so there will be predominantly, there are four patterns like linear, reticular, reticulonodular. Okay, so we have to see which is the dominant pattern. First we have to see which is the dominant pattern, whether it is reticular is the dominant pattern or nodular is the dominant pattern, whether it is high density or low density. Okay, high density pattern generally is seen in ground gas consolidation. Low density, so lung low density, interstitium low density can be seen in conditions with emphysema, cystic, if there is cystic lesions. Distribution of the lesions. The lesions are distributed in the central lobular region, central lobular area. So perilymphatic. The lesions are located in the interlobular septal. The interstitium disease is because involving the interlobular septal. That is perilymphatic. Random is disseminated throughout the lung. Disseminated spread. Random distribution. So that distribution as per the zones like upper zone, lower zone, central, or peripheral. Okay, high attenuations. There is ground gas opacity consolidation. So the density of the intrabronchial air appears darker as the air in the surrounding alveoli. There is a dark bronchus sign. Okay. So if there is intrabronchial air, so if there in presence of consolidation, we can find the air bronchogram sign. So this air bronchogram sign is as I appreciated is also called as dark bronchus sign because of the presence of the intrabronchial air. So you are able to appreciate the vessels if there is ground gas opacity. Ground gas opacity is somewhat like haziness. This ground gas opacity is also one of the interstitial lung disease changes. This ground gas opacity, it is a opacity, but we can see the underlying vessels. Whereas the consolidation, it is also opacity, but we cannot see the underlying vessels. So upper zone predominant examples are respiratory bronchiolitis. Lower zone predominant examples are usual interstitial pneumonia, non-specific interstitial, desquamated interstitial pneumonia. Central lobular distribution is, that is a central lobular respiratory bronchiolitis. The central part of the lobule. Low attenuation areas, low density. Low attenuation means low density. In these low density areas, interstitial lung diseases, best examples are air-filled lesions like emphysema. Of course, emphysema is obstructive lung disease. Only presence of emphysema cannot label as interstitial lung disease. Presence of emphysema along with other lesions like lung cystic lesions, fibrosis, then or bronchiectasis changes, then you have to suspect interstitial lung disease changes. This all comes under low attenuation, low density areas. First rule is to differentiate idiopathic pulmonary fibrosis from interstitial lung. If you suspect interstitial lung disease, firstly we have to rule out idiopathic pulmonary fibrosis from other idiopathic interstitial pneumonias. There are many idiopathic interstitial pneumonias. We have already described in the initial slides. So we have to differentiate this idiopathic pulmonary fibrosis from the other idiopathic interstitial pneumonias like non-specific interstitial pneumonia, acute interstitial pneumonia, desquamated interstitial pneumonia, cryptogenic organizing pneumonia, or bilateral arbitrans organizing pneumonia. Pneumonias. So we have to differentiate all these idiopathic interstitial pneumonias from the basic classical idiopathic pulmonary fibrosis. So in this classical idiopathic pulmonary fibrosis, there will be how to differentiate. There will be in this classical idiopathic pulmonary fibrosis the lung basal regions which will show extensive reticulation. It will give appearance like honeycomb appearance at the lung bases with the peripheral part of the lung with the traction, with or without traction bronchiectasis. Okay. So unlike other conditions like other idiopathic interstitial pneumonias. So how will you rule out the lung function? So we will rule out the lung function with the help of some diagnostic tests like pulmonary function test, diffusion lung capacity of carbon monoxide. So basically it will show restrictive pattern in interstitial lung diseases. Sometimes both restriction as well as obstruction can be also present, but generally restrictive pattern because of decreased lung volumes. So there will be decreased FE1 by FEC ratio. There is a force ratio of force expiratory volume 1 during the first second by force vital capacity ratio. There will be decreased vital capacity. The total lung capacity will be decreased in interstitial lung diseases. So mixed FT, both obstruction and restriction can be there. If there is associated emphysema changes, there will be associated obstruction also along with restriction. So we have to evaluate further clinically how is the patient with the help of some other tests like 6-minute walk test. So 6-minute walk test is this 6-minute walk test. It will give it will assess the lung capacity of the person. So we can assess the oxygen saturation before performing the test and after performing the test. Okay, we have to calculate the total distance the patient is able to walk in 6 minutes. So bronchoalveolar lavage. So the bronchoalveolar lavage is the bronchial washings, basically to understand you. this bronchial washings or the bronchial lavage is useful for in certain diseases of interstitial lung diseases. It is useful. So neutrophils predominantly are increased in conditions like idiopathic pulmonary fibrosis and asbestosis. Cells like inflammatory cells like neutrophils are increased in idiopathic pulmonary fibrosis and asbestosis. Lymphocytes are increased in hypersensitive pneumonitis orchidosis. So this bronchoalveolar lavage will correct by the investigative procedure like bronchoscopy, and we will send this for analysis for the lab analysis, where we have to look into the lymphocytes, neutrophils, how are these cells. So this bronchoalveolar lavage helps in the diagnostic analysis, ruling out infections, malignancies, pulmonary proteinosis. Okay. In sarcoidosis, there will be predominant increased T lymphocytes. That is, CD4 cells will be more, whereas in CD4 CD8 ratio will be increased. In hypersensitive pneumonitis, T lymphocytes increased, predominantly CD8 lymphocytes, predominantly CD8 cells. CD8 cells are increased in hypersensitive pneumonitis, whereas CD4 cells are increased in sarcoidosis. Idiopathic pulmonary fibrosis, there will be increase in neutrophils and eosinophils. So on biopsy, transbronchial lung biopsy. So this lung biopsy usually we have to do in only in selected cases of interstitial lung disease patients. If there is suspicion, if this interstitial lung disease is because of the usual interstitial usual interstitial pneumonia, or is because of the non-specific interstitial pneumonia. If there is suspicion, is this because of usual interstitial pneumonia, non-specific interstitial pneumonia? So in some selected cases, if the patient is fit enough, we have to analyze the risks and benefits. Then you can go ahead for transbronchial lung biopsy. So especially it is used in the diagnosis of like certain ILDs like sarcoidosis, infection, lymphadentic carcinomatosis. So this again video assisted thoracic surgery. So video assisted thoracoscopic surgery, VATS surgery. So this procedure also to take the lung biopsy to establish the proper diagnosis of the interstitial lung diseases. So surgical biopsy. Surgical biopsy we will get more bigger tissue that helps in more better diagnostic purpose. But this surgical biopsy, as of now, we are not doing surgical biopsy because there is one more biopsy like cryobiopsy. Cryobiopsy also it is very much we will get a good amount of tissue. So treatment, the specific therapy for individual interstitial lung disease is beyond the scope of the review. Okay, there are many drugs in the sense. So usually the drugs that are used, many trials were done. The many trials were done of the antifibrotic agents like pirfenidone. So in cases of like idiopathic pulmonary fibrosis, pirfenidone, nintedanib. Okay. And corticosteroids, especially, they have a role, especially in conditions like hypersensitivity pneumonitis and certain other connective tissue disorders. Corticosteroids, along with immunosuppressive agents like cyclophosphamide, azathioprine, have a role. And supplemental oxygen. Supplemental oxygen is also very important for these interstitial lung disease patients to maintain oxygen saturation between 88 to 92. Pulmonary rehabilitation with the help of some pulmonary basic aerobic exercise, lung function exercise, breathing exercise is also very important. Especially in patients with end-stage lung diseases. And lung transplantation, it remains restricted, but it is an effective option, lung transplantation. Again, lung transplantation, there is some criteria for the lung transplantation. Okay, so in case of in some these diseases like pneumoconiosis, there is some possibility of prevention of the progression of the interstitial lung disease in certain diseases. Like for example, in pneumoconiosis, removal of exposure. If the person quit from working there, from the coal worker or in stone quarrying industry, so he can avoid the disease progression of pneumoconiosis. Hypersensitive pneumonitis or extensive allergic rhinitis. So the person has to avoid exposure from the birds, pet, or any other pet animals. Collagen vascular diseases or connective tissue disorders, they have to use specific therapy. So drug reactions. So we have drug reactions, sarcoidosis, lymphadentis, leiomyomatosis, the progesterone is used. So vasculitis diseases, alveolar proteinosis, IPF, idiopathic pulmonary fibrosis. Generally, there is no definitive treatment in idiopathic pulmonary fibrosis. Only supportive treatment on antifibrotic agents or immunosuppressants can be used. Eosinophilic pneumonia, corticosteroids have a role. So idiopathic pulmonary fibrosis is the classical interstitial lung disease. So generally these are seen in age group people of greater than 50 years. Males are more predominant than females. There will be progressive breathlessness in these patients. There will be bibasilar crackles. There will be clubbing. Subpleural honeycombing appearance you will see. So idiopathic in this idiopathic pulmonary fibrosis, the classical pattern that is described as usual interstitial pneumonia. This usual interstitial pneumonia will see dense fibrosis with fibroblastic foci. There will be patchy lung involvement. Subpleural paraseptal distribution of the fibroblasts will be present. So again, these diagrams are showing subpleural with apicobasal gradient. So usual interstitial pneumonia will have apicobasal gradient. So as compared to apical regions, basal regions will show more and more fibrosis in this usual interstitial pneumonia pattern that is seen in IPF. So this is non-specific interstitial pneumonia pattern, NSIP pattern. This NSIP pattern can be because of again many diseases, maybe connective tissue disorders, hypersensitive pneumonitis, occupational lung diseases, drugs related. Of course, this connective tissue disorders, hypersensitive pneumonitis also can cause usual interstitial pneumonia pattern. But generally, the example that is a classical example of idiopathic pulmonary fibrosis, it will definitely show in almost 100% cases usual interstitial pneumonia pattern. Non-specific interstitial pneumonia pattern you will not see in idiopathic pulmonary fibrosis. You will see only UIP pattern, that is usual interstitial pneumonia pattern in idiopathic pulmonary fibrosis. But this NSIP pattern is seen in many diseases, many other diseases. This NSIP pattern is never seen in idiopathic pulmonary fibrosis. So this usual interstitial pneumonia pattern, so there will be apicobasal gradient. Predominantly the interstitial lung changes will be more at the lung bases. This apicobasal gradient will not be there in NSIP pattern. Heterogeneous distribution will be there in usual interstitial pneumonia pattern. Homogeneous distribution, generally homogeneous distribution will be there in NSIP pattern. Honeycombing will be there in UIP pattern. There will be ground glass opacities in NSIP pattern. There will be traction bronchiectasis because of the extensive fibrosis in case of UIP pattern. There will be nodular, there may be nodular structures, especially micronodules in NSIP pattern. These are the key imaging features that to differentiate from UIP pattern and NSIP pattern. The progress of the interstitial lung disease depends upon the age. So generally, old age group people are prone to worse prognosis. Male gender, smoking, honeycombing because of the extensive fibrosis. If the diffusion lung capacity of carbon monoxide less than 40%, if the 6-minute walk test, after 6-minute walk test is oxygen saturation is found less than 88%, if there is more and more higher rate of acute exacerbations, if there is associated pulmonary hypertension, so these are all prognostic factors. So again, if you see the classical idiopathic pulmonary fibrosis, so major criteria is the abnormal PFT with restrictive pattern, reticular opacity is predominant at the basal regions of the lung. Okay, and we have to extrude in this idiopathic pulmonary fibrosis. If you find usual interstitial pneumonia pattern, so usual interstitial pneumonia pattern can be seen in not only idiopathic pulmonary fibrosis, also in other diseases like connective tissue disorders, drug-related ILDs, occupational lung disease ILDs. So we have to rule out all the other causes. We have to rule out all other causes of this before coming to the diagnosis of IPF. So and we have to look into this minor criteria also. Minor criteria. So duration of illness, bibasilar Velcro type of crackles. So gradual insidious onset of breathlessness and progressive breathlessness. So elderly age group people greater than 50 years, minor criteria, and this major criteria. All we have to look into this, all this criteria before labeling as idiopathic pulmonary fibrosis. So other potential antifibrotic therapies for idiopathic pulmonary fibrosis like N-acetylcysteine. Okay, N-acetylcysteine with pirfenidone, azathioprine. So there are many trials were done on prednisolone, azathioprine, and N-acetylcysteine for the usage in pulmonary fibrosis. So pirfenidone, antifibrotic drug. This antifibrotic drug in case of fibrotic ILDs, it has a main role. It helps in decrease fibroblast proliferation. It decreases extracellular matrix production. It inhibits TGF-beta, fibrinogen mediator. It inhibits fibrinogen mediator like TGF-beta collagen synthesis. It inhibits mitogenic effects of platelet-derived growth factor. So by this, it will already decrease the fibrosis change. It will decrease the fibrosis changes. By this, all this protective mechanisms. So generally, the median length of the survival is idiopathic pulmonary fibrosis will be, IPF patients will have median length of survival of 2.5 to 3.5 years. So pulmonary hypertension is again major factor in these interstitial lung disease patients. If there is pulmonary hypertension along with the interstitial lung diseases, they will have very poor prognosis. So basically, when you are coming to the final diagnosis of these interstitial lung diseases, it is a multidisciplinary approach. So we have to involve pulmonologists, radiologists, pathologists. So all this, so physicians involvement, radiologists involvement, pathologists involvement should be there. So multidisciplinary approach is very important. So firstly, clinical approach. You have to take proper history, proper physical examination, proper lab investigations, pulmonary function tests. So we have to evaluate all this clinical history, physical examination tests. Afterwards, we have to see radiological investigation like chest X-ray, HRCT, and finally, if required, surgical lung biopsy. But lung biopsy, we have to be limited to very few group of patients. So from the very good history taken, from the good physical examination and the radiological point of view, chest X-ray and HRCT scans, if you see, in majority of the patients, you can come to a good diagnosis. So corticosteroids, prednisolone, like 1 to 1.5 mg per kg a day, this is given for 8 to 12 weeks and tapered gradually for a period of 12 weeks. So, immunosuppressive agents like azathioprine 2 to 3 mg per kg per day is to be given. So interferon gamma, perfluorine, N-acetylcysteine, all these are used in the treatment of idiopathic pulmonary fibrosis, or even these antifibrinotic agents like pirfenidone also used in non-specific interstitial pneumonia also, but in fibrotic cases. If there is fibrosis, if there is fibrotic NSIP, then you can use. Otherwise, you should not use. So other drugs like corticosteroids can be used in NSIP patterns related ILDs also. So on oxygen therapy, adequate nutrition, immunization, pneumococcal immunization, influenza immunization, pulmonary rehabilitation, these are all very important. On lung transplantation, if there is extensive fibrosis, you may consider, but so the criteria is there should be baseline dyspnea, DLCO should be less than 40%, 6-minute walk test oxygen saturation should be less than 88%, there will be extensive honeycomb, extensive fibrosis and HRCT scan. So after, again if you repeat this dyspnea score, F is forced vital capacity score, DLCO score, all these should be decline in all these functions. They should be decline in all these functions. Again, if you repeat after 6 months, there will be progression of lesions in HRCT after 6 months. So in these patients, group of patients, you have to consider lung transplantation. So the take-home points are the diffuse parenchymal lung diseases, the interstitial lung disease, heterogeneous group. Many other diseases many other diseases can resemble idiopathic interstitial pneumonias. Clinical, radiological, pathological. Clinical, radiological, pathological diagnosis is very important to establish the diagnosis of ILD. So trials of therapy without diagnosis are not recommended. So HRCT has a very important role in the diagnosis of the interstitial lung diseases. Thank you. So any doubts? Hello, are you able to hear me? Hello?
Yes, sir.
Any doubts, please? So to summarize you very briefly, interstitial lung diseases is also called as diffuse parenchymal lung diseases. It involves almost throughout the lung. So first, history is very important to establish the diagnosis of interstitial lung disease. After proper history taking, we have to send for investigations, lab investigations, and pulmonary function test. We have to see whether there is obstructive pattern or restrictive pattern. So radiologically, CT scans, chest X-rays we have to send. We have to observe findings whether there is a reticular pattern, reticulonodular pattern or nodular pattern or honeycomb appearance is there. Okay. When you come to the treatment, we have to use fibrinotic drugs in case of fibrotic ILDs. Fibrotic ILDs is idiopathic pulmonary fibrosis or fibrotic NSIP diseases. In non-fibrotic diseases like NSIP diseases, NSIP pattern diseases, we have to use many other drugs like corticosteroids, immunosuppressants. And pulmonary rehabilitation is also very important to improve the morbidity and mortality of the ILD patients. Are you able to hear me?
Yes, sir.
Yes. Do you have any doubts, please?
No, sir.
Okay. Hello? Hello?
Yes, sir.